It's almost as if people think that there's some kind of style of doctor that they've got to pretend to be, even if they're not, in order to impress the examiners. There is a bit of a myth out there that role players are sometimes programmed to be difficult. All the scenarios are going to have an element of danger. It's your job to keep them safe.
In this video, we're joined by Neighbour, renowned for the GP consultation. We dive deep into the SCA, breaking down misconceptions, showing you insider tips, how to pass your exam. If you're a GP trainer, you'll also get a lot from this video. My guest today is Neighbour, has decades of experience in psychology of the consultation and has been helping GPs with their consultation skills. Hi, Roger.
Hi, Erwin. Thanks for the introduction. It doesn't seem like that many decades.
Let's go over common misunderstandings that you have noticed while you've been helping GP trainees, Roger.
Yeah, sure. I guess probably before we get into that, Erwin, I should just make clear to your viewers and listeners, I'm speaking just as me. I don't have an official role within the exam or within the college. So these are although I think I'm pretty well informed about it, and it's a great pleasure to share my own personal thoughts about it. But I suppose I perhaps ought to say that the real source of actual sound information about the exam is actually on the college website, and there's a huge amount of stuff there, which is probably a really good tip to your viewers. To make themselves really aware of that website. Anyway, as we were saying,
what are the things that you've noticed that some GP trainees might not get when it comes to the SC exam?
There's lots of detail we can talk about, but maybe first of all we could just think sort of broad brush about it. As you say, it's been my privilege over the last few years to work very intensely with some of the candidates preparing themselves. And I suppose the thing that worries me most about some of the candidates is that they regard the exam as a battle against an enemy. I guess if you start to think that the college is the enemy and the examiners are soldiers who are armed against you and trying to make you fail and do you harm, that puts you on the defensive and it doesn't bring out the best. The reality is very far from that. Nobody ever believes people when we say this, but the examiners want you to pass. They really do. If I can sort of speak rather pompously on behalf of the profession, as it were, we need all the GPs we can get. And you guys who've been training for general practice have spent 10 years of your life readying yourselves to join the profession. We really want you to do so, but because it's a licensing exam, the college does also have a loyalty to the GMC and to the public to make sure that the people we pass are really up and ready. But nothing would give the college greater pleasure than to have a pass rate of 100%. And I think where we see sometimes candidates going wrong is they suspect there's a trick around every corner and that there's a pitfall waiting for them to fall in, and all the scenarios have got hidden agendas and stuff. It really isn't like that. And overall, the best advice I think one can give to exam candidates is relax, try to forget that it's an exam, and just do the very best you can for the doctor in front of you. I just one or two perhaps other things that are worth commenting on before we get into the detail. An exam consultation, just like any other consultation, doesn't follow a script. It doesn't follow an algorithm. It isn't a set of rules that you've got to obey. And it isn't a minefield to be negotiated and avoid being blown up. It's a conversation between two human beings where one is trying to help the other. And I think as long as you can relax, forget about it as some kind of confrontation or fight, that makes it easier for people to relax.
If we had to say it in a nutshell, what exactly are the examiners looking for, Roger?
Two things. Firstly, you, if I can, not you, Erwin, but you, our listeners and viewers, you've got to show us that you're safe. That's the ultimate criterion. The exam it comes at a transition point in your careers as you move from being in a supervised role to an unsupervised role. And the first thing you've got to do is to show that patients are safe in your hands. So all the scenarios are going to have an element of danger, not to you, but to the patient. And it's your job to keep them safe. And the second thing that they're looking for is independent. After you've passed the exam, which is the gateway to the to the CCT and your future careers, you're on your own. Largely, there are colleagues around you, but you have to make your own decisions and justify them. And so, again, there will be decisions that are involved in all the scenarios that you have to make on your own and be prepared to justify them. So safe and independent are the main things. And in terms of outcome, I think the examiners in all cases, again, are looking for two things. And this, I think, we'll perhaps talk a bit more about how we address the management part of the consultation. Um, Again, two elements to that. Firstly, it's got to represent sensible medicine, not necessarily the last ditch small print, fine print, last word in medicine, but the sort of medicine that patients have a reasonable right to expect their GPs to come up with. So you've got to come up with with a management plan that is reasonable clinical medicine. But also, and this I think is where some candidates, and particularly those perhaps from a different background, which I expect we'll talk about, where some candidates find difficulty, is incorporating the dreaded ideas, concerns, and expectations agenda. That dreadful phrase, ideas, concerns, and expectations. It's important for a reason, and the reason that it's important is when it comes to management. If your management plan is just good clinical medicine but doesn't take account of what the patient wants and needs and is expecting, then that's not going to go well. So again, just to recap, you've got to show that you're safe. You've got to show that you can make and justify your own decisions. You've got to come up with a piece of reasonable clinical medicine that incorporates what the patient also needs from the consultation.
When it comes to learning and teaching consultation, you have a lot of experience in it. What are the things that you've noticed candidates they waste a lot of time, Roger?
If you look at the performance of candidates who don't do so well in the exam, the area where most marks are lost is in management, and that's usually not that the candidates don't know what to do, but they don't leave time to do it. And so most of the not wasted effort, but the misplaced effort goes into too long spent on technical information, technical data gathering. We've all been trained as medical students in hundreds and hundreds of questions about symptoms, which we can ask patients. And if you're clerking a hospital patient, you can ask questions for half an hour and still have more left to ask. You can't do that in general practice. You can't do it in the exam. In the exam, you've got 6.5 minutes to get your questions in and to get your story out. And so the art of asking or getting information that is relevant and not getting information that is irrelevant, that's the ideal. It's tricky to achieve, of course, and I can give some tips as to how to do that. But focused questioning, I think, in knowing to ask questions where the answer is going to make a difference, rather than just asking questions for the sake of asking questions.
So sometimes people might ask 2 or 3 questions to get the answer. So for example, recently a GP trainee was practicing and was saying, have you had any weight gain, any weight loss? Whereas if you ask the patient any change in your weight, then you get the answer. So sometimes the questions are not sharp.
And also, I mean, I'm going to come very strongly in favour of asking open-ended questions rather than closed questions. For instance, if a patient comes to you with what sound like symptoms of prostatism, you can say, have you got any hesitancy? Have you got any nocturia? Have you got any frequency? How is your stream? That's 4 questions. Why not just say, how's it affecting you? The patient will tell you that stuff. And the patient will also tell you that it's worrying his wife because because she's not getting a decent night's sleep, which you weren't going to ask that question, but it might be a terribly relevant fact.
Absolutely.
Open questions, particularly when you get data gathering, much more rewarding than a series of closed questions.
So when it comes to the role players, Roger, what information are they given?
The role players, they're all professional actors. I mean, what a way to earn a living, going around just pretending to be ill all the time. But they are professional actors, and they're very good professional actors. And I think that's one of the misunderstandings is that they work from a script. They don't work from a script. They work from a detailed description of who they are and the situation that they're in. So, for instance, a role player might be told, you're so and so, married to so and so, age so and so. This is your background. This is the work you did. This is the family you come from. This is what you hope to do with the rest of your life, and these are the symptoms you're getting. And so the only bit that is actually scripted, i.e., is word for word the same in every performance, is the opening remarks. They will be trained to say, "Hello, doctor, I've come to see you because I'm worried about my knee." And that's the only bit that will actually be scripted. Everything that happens from then on will be their improvisation based on the character description that they've known and studied and are fully aware with, and responding to how you, the doctor, deal with them. So there is a bit of a myth out there that the role players are sometimes programmed to be difficult. No, they're not. They will be difficult if you don't help them tell their story. And they will be easy if you do help them tell their story. So they, as I say, they are not programmed to say certain things or withhold certain things. They have all the information. They know their characters inside out and backwards, and they will tell their story to you just like a real patient does. And if you help them tell their story, you'll get it. And if you cut across them and interrupt them and don't seem to be listening, you won't get their story.
Absolutely. And one of the things that you talk about in consulting in a nutshell is person-centered care, where you empathize and you put the patient at ease. Share a little bit what tips can a candidate actually use to make sure that they get the best from the story.
In exam cases, just as in real life, the first few moments, first minute or two of the consultation are really, really important. If that gets off to a good start, everything goes sweetly. If you get off to a bad start at cross purposes, then it tends to go from bad to worse, doesn't it? So I think getting those first few moments right, they set the tone, as it were. And the ideal way to start, I think, is for you to be welcoming and to appear interested, and to make sure that the patient knows that you're attentive, listening, ready to talk, not distracted, not looking at the computer, not writing on your notes, but giving them your full attention and seeming to be welcoming and interested. Then they will respond to that, just like any other human being does in a social situation. And I think I don't think rapport is something you have to structure. A good rapport emerges between two people if they care about each other, or are interested in each other. It's not a question of play acting good rapport. Good rapport happens naturally if you're interested and attentive and curious.
It's good that you mentioned that it's not about acting, because some candidates, they feel like it's artificial and they try and act, but it doesn't usually work well.
It doesn't work. No, it's almost as if people think that there's some kind of style of doctor that they've got to pretend to be, even if they're not, in order to impress the examiners. It's simply not the case. There are over 200 examiners from all parts of the country, all backgrounds, all both sexes, all sorts of different practice settings. So there is no one style of general practice that the exam is trying to look for. I mean, richness and diversity of style and approach is one of the great virtues of general practice. The fact that there are so many ways of achieving good medicine. So there isn't any college-approved model of the consultation, college-approved style of doctor, college-approved phrases you have to come up with. It really isn't that. The examiners, as I say, are A, not the enemy, and B, they're a very diverse lot. And I'm sure you know good practice when you see it. They know good practice when they see it.
Among the IMGs, there are some challenges that we have observed. In your experience, what are the reasons the IMGs struggle?
Yes, it's a constant concern, that, isn't it? I suppose let's keep it in proportion to this exam is no different from any other medical exam. In fact, in this country, many exams from other professions, from law or accountancy, experience that same cultural gap between the performances of candidates who've grown up and have been educated in the UK system and the UK culture, and others who, for various reasons, have come to this culture later in their life, where English is probably not their first language. There are various things that the college tries to do to reduce that. They call it an attainment gap. That's the jargon for it, and it's by no means peculiar to this exam. It's a universal finding in all medical exams. I think what's at the bottom of it, we can't deny that language does come into it. I mean, I speak French reasonably fluently, but not fluently enough to be able to work as a clinician in France and understand all the nuances. And I wouldn't expect to. I would find that very difficult, and it wouldn't surprise me if my French patients found it difficult to talk to me. And I think the same is bound to apply if a patient has difficulty in being understood or difficulty in understanding what's being said to them. I'm afraid that cannot fail, but to make for a more difficult consultation. Um, but having said that, I mean, in my experience, the command of English of our IMG colleagues is fantastic. I mean, really admirable. So I think probably a greater cause of it um, is the fact that many people who've qualified overseas have worked and been educated in healthcare systems where the dynamics and the structure and the expectations are very different from the UK. In the UK, in general practice now, as you know, the expectation is that it's more a conversation between equals. General practice is not a hierarchical profession. GPs don't sit within a hierarchy of seniors and juniors as our hospital colleagues do. And I think that transition from working in a hierarchical system to a non-hierarchical system is harder for IMGs in many cases for that reason. So I think that goes a long way towards explaining it. And I think the other thing is to many of our IMGs have had careers that have been perhaps they've probably spent longer in hospital medicine than some of our UK colleagues. Many of our UK trained colleagues go into general practice training straight after their F2 years. And tend not to have had their hospital styles reinforced by several years of hospital training. And I think that making that transition from a hospital style of working to a general practice style of working is more difficult. The more years you spend in hospital, the more entrenched that gets, and therefore the more difficult the transition is. I hope that makes sense. It's
Yeah, that makes sense. So we see the difference mainly in the clinical management, where what you've mentioned about the training and the hospital type of consultation where the doctor seems to know best is applied in the clinical management, and that's where it doesn't learn well.
That's true. Yeah, we use these phrases patient-centered and doctor-centered, don't we? We toss them around, and the general assumption is that patient-centered is good and doctor-centered is bad. Um, and that's not true, of course, and at least it isn't as simple as that. But I think if a doctor has a tendency to be doctor-centered, it tends to show most in the management part, where, of course, the doctor has some expertise and a greater knowledge of possible treatment paths and outcomes and so forth. Um, and it's very tempting and a piece of behavior that we quite often see in less successful candidates when it comes to management is to say to the patient, right, you've got this condition and this is the treatment for it. You will now do this, I will now do that, and this is what's going to happen. And that may be good medicine, but it's forgotten that bit which I was talking about earlier. That doesn't necessarily satisfy the patient. Good clinical outcome is, of course, necessary, but it's not the whole story. And that good clinical medicine has to be involved, has to be supplemented, as it were, with does that fit the patient's expectations? Does it answer their questions? Does it set their mind at rest? Which is again the ideas, concerns, and expectations agenda coming into play. That tends to be the bit that gets lost in less successful management sections.
When it comes to advice, for example, let's say a patient is smoking and that candidate wants to advise a patient. So if somebody tells someone else what to do, it might not be taken very well. Whereas if we involve the patient, it's different, they're more invested. So tell us a little bit about what are the tips you'd give somebody in the clinical management, how to explain these advice.
The figures on how effective any GP is in stopping patient smoking are pretty depressing. I'm sure you've said, as I certainly have in my time to various patients, that you really ought to stop smoking, and they say, "Yes, doctor, quite so, doctor," and go away and do absolutely nothing. So telling people what to do on things, particularly on lifestyle things, is totally ineffective. Um, I must admit my inclination is to try to steer clear of that sort of thing, really. I think people who've got a chronic chest and smoke 40 a day know perfectly well that they ought to stop smoking. And being told that they ought doesn't actually add anything. Um, so I'm I think that there are better ways of helping people stop smoking than just kind of tacking the advice on at the end of a consultation about something different.
When you know the person much better, then you can use their concern that way. They might be more alert as in the problem when they're smoking. For example, let's say if you've got somebody who has problem with fertility and they're smoking, if we link that the problem with fertility and the smoking, then they might be more incentivized to stop smoking.
Yes, I'm sure that's true. Yes. I mean, it's all about motivation, isn't it? I mean, uh, within limits, you can do more or less anything provided you're motivated. So generating the motivation, I tend, this isn't necessarily relevant to the exam, but I've had quite an extensive background in clinical hypnosis, where sowing the seed of an idea or a suggestion is much more powerful than a direct order. So saying something to a patient like, I don't know whether you're ready to stop smoking yet, you probably are, but when you are, I've got some, I could tell you, I could help you with that, which is slightly teasing, but it's just likely to leave that slight question. I wonder what the doctor had in mind, you know. Those sorts of indirect methods, I think, are much more effective.
So now let's talk about people who've failed the exam. It's a
Yes.
different approach once they've failed the exam because now they're carrying more of a stress with them.
Yes, it's really hard that, and I think the let's just think about we've talked briefly about some of the reasons why a candidate might fail an individual exam, but let's view that in context about timing when you sit it, for instance. There's a kind of Goldilocks zone that's neither too soon nor too late. I guess it's tempting, and I can perfectly understand that. You know, with an exam that you think you might fail, and you're running on the clock with your training, the temptation is to sit it early, get it out of the way, and hopefully pass it. Well, unfortunately, that's not necessarily a good practice because the best preparation for the exam is to see lots of patients. And we do sometimes see candidates who sit the exam after they've just done a couple of months of general practice. You really haven't seen enough about general practice to do yourself justice at that stage. I think the general consensus, and I've heard examiners saying much the same thing. The ideal time is about halfway through your training, whatever that is, whether it's full time or part time, but about halfway through is about the right sort of time. So that's one thing. One reason for failing may be that you've actually taken it too soon before you're actually ready. And I think you really should have a serious discussion with your trainer about when you're ready. Um, there's no point taking it when you're almost bound to fail. Why would you do that? It's going to cost you money and going to depress you.
Are you feeling unsure about the SCA? Maybe you don't know what to do or you don't know whether you're doing the right thing. If you'd like to get a free copy of the SCA blueprint, click the link down in the description below to get access to the SCA blueprint that GB trainees have already used and passed the SCA exam. It's completely free. Just click the link down in the description below to get access to it.
When to sit it. As you know, the SCA cases last exactly 12 minutes. You've got to be capable of running a single issue consultation, which most of them will be single issue consultations, running that from start to finish in 12 minutes. And so I think if you're still working to a 15 or 20-minute booked surgery time, you're probably not working fast enough to do yourself justice. So you really ought to be able to run a consult to have your regular consultations booked at, let's say, 12 to 15-minute intervals and be reasonably comfortable. Most of the time you can stay on time with that. Because as I say, virtually all the SCA cases are going to be single issue things. They're not going to be patients with lists or while I'm here's. They'll be single issue consultations. So we're making sure that you're in the habit of being able to run a 12 to 15-minute consultation, I think is important. If you are unfortunate enough to fail, the way the exam booking system works If I learn today that I failed, I can't, because of the booking windows. I can't book for the very next sitting. The booking window has already closed by now, and that's intentional. Because if you do fail the exam, you will be given some feedback statements. There'll be generic feedback statements, but they'll be as helpful as possible, giving you some stuff to work on. And there's no point resitting it just to fail for the same reasons. So if you are unlucky enough to fail, take seriously the feedback statements that you get. Discuss them with your trainer. Of course you'll be disappointed, probably a bit resentful. Probably say what are they've never seen me in real life. What do the examiners know? After that reaction has died down, take it on the chin. Discuss that feedback with your trainer. Work on those issues. And the success rate is the pass rate is around 70% overall for first time takers. But by the time you've had two or even possibly three exams, that pass rate has risen well into the 90s. So the odds are very much that if you do resit and put some work in on the issues that have been suggested to you, the odds on you passing the second time are much greater.
Trainer plays a very important role in somebody's preparation.
Yeah.
How could a trainee get the best out of the trainer?
Increasingly, I think that those of us who are kind of on the kind of tutorial circuit for this exam, we're increasingly being asked to and are happy to provide sessions for trainers too. The same advice goes to trainers as it does to trainees. Know your way around the website. Virtually the answer to every question is on there somewhere. Um, uh, Trainers can help in a number of ways. Really important, since the exam covers the entire curriculum. Many GPs only, because of their pattern of work, only see a subset of that. For instance, female doctors tend to see more women's problems in gynecology and problems of pregnancy and so forth, and menopause, inevitably. They're not so good at dealing with male infertility and prostatism, and vice versa. Whereas the exam is quite likely to cover the entire curriculum. Well, will cover the entire curriculum. So one thing that trainers must do is to make it possible for trainees to see patients from right across the board. And that means, if necessary, instructing their reception staff not always to book female patients with the female doctor. It may involve, for instance, having some a swap in practice, perhaps a placement in a colleague's practice to get a different piece of experience. So in terms of just organising the trainee's experience, that is very largely down to trainers to do. Other things I think trainers can help with by being role models. Trainers are by and large excellent doctors in their own right. Sitting in with your trainer and just watching a good doctor at work it's almost kind of role modeling, and I think that there's a lot to be said for that. We tend to have trainees sitting in at the beginning of their attachment, but to do that periodically as trainees become more sophisticated themselves, I think they can pick up more sophisticated stuff from seeing their trainers and other good colleagues at work. What else can trainers do? Did you have any thoughts yourself, Erwin?
Last time we spoke, you mentioned about the importance of recording and reviewing the consultation.
Indeed, yeah. Yes, I suppose the first thing that a trainer needs to do is to provide a decent video camera. Which they do. And I think they're aware of that. Certainly, one of the best self-preparation tools is to record yourself and watch yourself. I think if candidates do nothing other than record themselves and watch themselves at work, even without anybody watching or a trainer helping them with it, there's a lot to be learned. But a trainer, I think, can be very useful in watching a trainee at work, either by sitting in or more likely on a video recording, by making exam-focused comments, by saying things like, did you know that you interrupt the patient a lot, or the patient doesn't seem to understand what you're saying, or you don't seem particularly interested, or you've left it very late to get onto management. I think for a trainer who's well versed in what the exam is looking for, and to have the help of such a trainer in reviewing one's own video consultation is tremendously valuable.
When candidates review their consultation, some of them, they don't know what they're looking for. Are there things you would advise them to think about? What are the consideration when they're doing that?
If you understand how the exam cases are marked, and it's not complicated, it's well known. You'll get marked on your data gathering, you'll get marked on your management plan, you'll get marked on your interpersonal skills. And you'll be marked very good, acceptable, not quite acceptable, and poor. And I think if you watch your own consultations against that kind of mental template and say, what's the quality of my data gathering? Am I getting the data from the patient effectively and efficiently? Is the medical data I'm getting, is it relevant and well focused and well chosen and helpful? When I come onto the later parts of the consultation, is my management plan clinically sound and addressing what the patient wants from it? To be able to introspect, as it were, and to apply an exam template to one's own work, I think that's a good idea. As I said, there's no approved college model. I don't think it's helpful as part of exam preparation to start using other people's models of the consultation, even my own included. The time for learning your generic consultation skills was months ago in the early stages. When you're coming up to be assessed against an exam template, use that template to reflect.
There are many ways of consulting, and everyone would have their own style. So if it's working for you, then that's what you want to use in the exam.
The examiners don't give a toss whose model of the consultation you're using. They really don't. Honestly, they don't give a toss. If you can have a consultation where you work out what the patient's problem is satisfactorily and you come up with a plan for dealing with it effectively, don't care how you get there, that's great. And as you rightly say, we all develop our individual styles, and even this early in a GP's career, at the end of a traineeship, people are starting to develop their own styles, and they'll continue to do that for a number of years afterwards before it beds down into their sort of maturer style. It's great to see different approaches, provided they work, provided they keep your patient safe, that you make reliable judgments, and you deal with what the patient wants from the consultation as well as the medical agenda. How you do it, nobody minds.
As long as the outcome is satisfactory and it's a safe management plan, yes. So tell us about managing that stress, because you mentioned candidates ideally they want to be relaxed to do the exam, but that's really difficult.
If only. As you probably know, I get to work on quite a lot of SCA preparation courses, and that's a question everybody asks. Nobody has the answer. In the exam, you've got 3 minutes between 3 minutes before the case starts, during which you can read the case notes, which will appear on the screen. Most of the time, it doesn't take 3 minutes to read the screen. It's possible, if you want to get up and have a leg stretch, take a deep breath. One of the delegates on a course I was running a couple of weeks ago said that she had learnt to do a half-minute breathing exercise, which she found helped center her and helped to get it. And that's fine, whatever, if it works for you. Other things that I think can work is to have a picture or a photograph on your desk of someone that reminds you of why you're doing this job at all. Maybe a family member or a pet or a favorite landscape or whatever it is that relaxes you. And I think the other thing to do is I think out of your 12 cases, of course, one or two are bound to go worse than others. Try not to be haunted by that. There is no such thing as failing the exam because of one bad case. It doesn't work like that. All the marks from the 12 cases, are added up at the end. And how you get the total number of marks, nobody minds. So if you have one particular bad case that goes badly, it probably doesn't matter. You can just try and do a little bit better on one or two of the others, and that will compensate for it. So try not to get haunted and think, oh, I've blown it now. I shouldn't have done that. I should have said that. But if anybody knows any successful ways of blanking out what you've done in the last 15 minutes and starting afresh, I think we'd all like to know that secret. I think people's experience is that, of course, the first case you're anxious, you're at maximum adrenaline in the first case. By the time you've done one or even possibly two out of your 12 cases, the artificiality is gone. You're into the groove. You're just doing the next case. And by and large, the nerves tend to settle quite quickly.
It is really important for people to have maybe practice like a mock so that they understand what it's like to be doing this consultation back to back. The other thing is making sure that all your IT setup is working properly, because that could cause unnecessary stress.
Yes, indeed. That's why they have the system which they call onboarding, which happens a few weeks before your exam, where you will be in the room. You'll be doing the exam with the apparatus and the IT that you'll be using. And it's an automated process, but it checks on the camera, the sound system, and everything else to make sure that the IT is working. The exam uses a platform called the Osler platform, which is widely used in medical exams on this basis. It's never been unreliable, and its reliability is superb at the moment. At the last case, I think I heard the chief examiner quote some figures that 99.7 something percent of the candidates had entirely smooth IT issues. If it goes wrong, it maybe there's an electrical blackout, or somebody cuts the cable. In the background, for each of your for every candidate, there is an invigilator in the background who you can contact on the screen or by telephone. If there are any IT issues, will help you resolve them. And if that means rerunning the case at the end of the day, that can happen. Unfortunately, I don't know whether it's still relevant, but on the very first iteration of the exam back last September, whenever it was, when it first ran for the first time, there was an IT outage that affected about 40 or 50 candidates, which was a worldwide outage, nothing to do with the college, nothing to do with Osler. It took out Amazon, it took out all sorts of other websites as well. That was a one-off. That's never happened again. There's no reason why it should. And most candidates, particularly if you pay attention during the onboarding session, which will talk you through what the screen looks like, where the clocks are, where you can find the notes, how you can where you can make notes if you want to. Most candidates afterwards say that the IT was much better than they thought it was going to be.
So we've already been 1 year in the SCA era now.
Yes.
So the first one was in November, I believe, and that's when there was the IT outage.
Yeah.
What were your thoughts about, when you reflect back from a year, what happened?
My impression is that the anxiety about it, which was perfectly understandable, is dying down, not least because of information such as you yourself are generating. I think people have got used to the idea that it's a remote exercise rather than a face-to-face. My impression is that it's not a big issue anymore, is the impression I get. I mean, we had similar discussions about difficult pass rates and why people pass and fail, about all the exam's predecessors. It's certainly an improvement on its immediate predecessor, which was the recorded consultation assessment, the RCA, where you had to submit recordings of yourself working live with patients. That was fraught with difficulties. From the college's point of view, the reliability figures are great. A huge amount of analysis goes on behind the scenes about how exams are functioning, in terms of, are they reliable, are they fair, are they consistent, and all those sorts of things. And there's a whole industry behind that, in terms of reliability quotients, and we talk about Cronbach's alpha and kappas for and so forth. The alpha coefficient for this exam, which is the broad brush measure of reliability, is far better than any of its predecessors for this exam. It's the most reliable and consistent form of clinical exam in the world at the moment, if you take the Cronbach's Alpha as the marker of that.
So, anything else that we haven't touched that you'd like before we wrap up, Roger?
Yes, I think I'd just like to emphasize what I said at the beginning. It isn't a game. It isn't a trick. It's you giving the college the privilege of eavesdropping on your normal work. And the best way I think you can have to prepare for it is to put the work in early in your traineeship. To be interested in the consultation process and to find ways of enjoying that contact, so that you get into the habit of listening to your patients and working out what's going on in their minds and trying to help them with stuff. And then on the day, just do what you always do. Don't try and don't perform for the examiner. Just do what you always do and trust the examiners to know good work when they see it, because they do.
If you've listened or watched until the end, please write down in the comment what was your main takeaway from this interview with Roger Neighbour. Thank you so much, Roger.
It's a pleasure, Owen. Thanks very much indeed for the opportunity, and let me on behalf of myself, of course, but if I can, on behalf of the college and the profession, wish you all the very best, and we hope to welcome you into the profession very, very soon.
Great. Take care, everybody. Bye-bye.